My name is Dr. Ken Alleyne, a sports medicine and joint reconstruction surgeon. And we have a series of videos that we're going to discuss some of the more common things that we see here in my orthopedic surgery and sports medicine practice. By way of background, I am a board-certified orthopedic surgeon. My training has occurred at many places around the country, including Williams College, Medical School at Wake Forest University, Howard University Hospital for residency, Yale University for my sports medicine fellowship, and then a research fellowship at Harvard MIT in Cambridge. The majority of my practice are problems of the knee and shoulder, and our practice here at Eastern Orthopedics and Sports Medicine ranges from school-age kids to active seniors, professional athletes, collegiate athletes, and Olympic athletes. So we have a pretty diverse practice. What we'd like to do today is discuss a series of the more common things that we see in hopes that it will help to direct our patients in their care to ask the appropriate questions of their doctor and to make sure that they have good information in regards to their orthopedic concerns. Tears to the ACL, or the anterior cruciate ligament, is a very common problem in active people in the United States and around the world. For various reasons, we certainly see this injury more common in active girls and women than men, but it's common in both. Diagnosis, treatment, and return to an active lifestyle certainly should be the goal of the physician and patient working together in the event of an ACL tear. The anterior cruciate ligament, or ACL, is the ligament that helps to connect the thigh bone, or the femur, part of the knee, to the shin bone, or the tibia, part of the knee. And it's a ligament noted right here. Now, ligaments, by definition, help to attach bone to bone. Tendons, such as the rotator cuff, attach muscle to bone. So the anterior cruciate ligament, cruciate meaning cross, anterior meaning in front, is the ligament in the front, crosses with another structure called the posterior cruciate ligament, or behind, and attaches the femur bone to the tibia bone. In sports, this ligament also helps to create a check rein, or a tether, to stop the femur bone from moving too far forward on the tibia bone, and actually helps some with some rotational motions as well, imparting stability to the knee. When a patient tears the ACL, often they will note a pop. It's usually a non-contact injury, meaning most ACL injuries occur not because of contact with another athlete or not because of contact with another person or an object. It's usually with a planted foot, some form of twisting, a pop, and in many patients will note pain and swelling in the knee. When you see your orthopedic surgeon, that diagnosis is often made by physical examination and history. If there's significant swelling in the knee, your orthopedic surgeon may suggest removal of that fluid, which is often blood, from the knee in an attempt to get the knee moving again. X-ray and MRI may be ordered to help confirm the diagnosis and to evaluate for any other injuries. The goal then will be to restore motion to the knee as soon as possible. Management of ACL tears really is very dependent on the patient and the physician, in fact. There are some physicians who believe every ACL tear needs to be reconstructed. Others, like our practice here at Eastern Orthopedics, we believe it really needs to be about the patient, their needs, their demands, and the symptoms that they present. For instance, a patient who presents to me, works in an office at a desk, happened to tear their ACL playing soccer, no other problems except when playing soccer, and says, soccer really isn't that important to me. I can give up soccer. I don't have any problems playing tennis. I don't have any problems playing softball. I don't have any problems walking around my house or carrying out my activities of daily living. If I can just get back to those things, I would be happy. Would be a patient generally that I wouldn't consider, at least initially, for reconstruction if their knee is otherwise stable. You should think of ACL surgery as surgery for an unstable knee, meaning a knee that's giving away or locking or somehow not giving you a sense of security when walking. Generally, that patient would go to physical therapy, carry out significant therapy on their own, and may even utilize a brace to help impart a sense of stability to the knee. For the patient who does not have that stability, or certainly for the young athlete with an injury to the knee, surgical stabilization reconstruction is often indicated. the risk of an unstable knee are quite significant. Every time that knee becomes unstable or gives way, there's an opportunity to injure other structures within the knee. Some of the more common structures that can be injured are the articular cartilage, or the smooth cartilage of the knee, which can lead to arthritis, or the meniscal cartilage, which are shock absorbers and other stabilizers of the knee. Each time that knee is unstable, these structures can be injured and can cause a larger problem for the knee. Now, reconstruction of the ACL, certainly in 2012, and with a board-certified sports medicine physician, is largely going to be arthroscopically assisted or all arthroscopic reconstruction. The type of reconstructions are immense, and that really would be a decision made between yourself and your surgeon, but would include utilizing tissue from yourself, i.e. what we would call an ACL graft, which may come from several areas. Sometimes the graft is harvested or taken through a second procedure at the same time from the front of the knee, which is probably the most common. It's the so-called bone-tendon-bone graft, or a piece of the patella bone, a piece of the patella tendon, and a piece of the tibia or shin bone. This piece is lifted out and woven back through the knee and fixed in many ways, usually with screws, on both the femur side and the tibia side. And those screws you can't see and would not hopefully be felt by you at all. Other types of grafts that are utilized are a quadricep graft, which we may take from the quadriceps tendon above the patella or the kneecap, and hamstring grafts, which we would take from some of the hamstrings that insert on the side of the knee. In addition, your surgeon may discuss with you allograft, which is a cadaveric or a cadaver donor graft. These donor grafts are much safer now than they used to be, and are generally thought to be very safe, with the chance of disease transmission somewhere in the neighborhood of 1 in a million, literally. There are pluses and minuses to both, and you would need to discuss those with your surgeon. Some things that may drive you to one decision or the other may be the type of sport that you do, any prior history of surgery on the knee, your need to recover quickly to engage in your sport, and your overall goals in terms of fitness and activity. Rehabilitation for ACL surgery in our practice begins pretty quickly. Patients generally go home the same day after the surgery. They're allowed to put full weight on the knee. They may need crutches for 1 to 2 weeks, and then we get them immediately into physical therapy. Now, that therapy can often last 3 to 4 months, and generally return to full activity for a high-level athlete is anywhere between 5 to 6 months. Things like jogging and walking is encouraged relatively early on in the process. In our practice, jogging can start somewhere between 3 to 4 months, and walking is allowed immediately. During that time, you will often be utilizing anti-inflammatories, ice, and maybe even a brace to help your knee while you recover. But each physician has their own post-operative rehabilitation protocol, and your rehab should be done in consultation with your sports medicine doctor. ACL reconstruction is a very, very successful surgery. We can return athletes back to a very high level of care. High level of activity, both at the professional, collegiate, high school level, as well as the weekend warrior. Again, in our practice, we feel the ACL surgery really has to fit the patient, and there are many times, and with many patients, who we can get them to be completely functional, enjoying a very active lifestyle with no instability in the knee, and we will monitor them, but they may not require arthroscopic or other types of reconstruction. Certainly, should you have any other questions about ACL reconstruction, please don't hesitate to visit us at www.eosm.net.